Thank you very much, Mickey. Why don't you join us here on the podium for the completion of this debate, and I'd like to open up the floor to the audience for any questions or comments before you all decide for yourselves whether there's a more convincing argument for aggressive medical management, or is there a role for stenting for symptomatic intracranial disease. So any questions?
Can you guys hear me?
Yes.
I think I have a question for Dr. Smith. I think the one question we did ask Dr. Chimowitz was that in patients who have failed medical therapy, they're optimal medically, we discussed whether, who would you consider for stenting and who would you consider for bypass? And he told me to ask a neurosurgeon.
Yeah, I think the one, someone has to be a surgical candidate to undergo a bypass procedure and the actual procedure itself, but I think the difference may rely really in the degree of stenosis versus full-on occlusion. These patients who've shown to really benefit somewhat from a bypass are those patients who actually have these chronic steno-occlusive disease, whether it's from an underlying Moye-Moye disease or Moye-Moye syndrome from progressive intracranial atherosclerotic disease. And these patients with hemodynamic compromise and those patients who don't have a lot of vascular reserve, have lost their autoregulation, those are the patients we think would be better surgical candidates likely than upfront stenting candidates. But I think the bottom line is probably the stenting candidates would be those who don't actually have a full-on occlusion and have not developed these collateral circulations and who may still have some degree of autoregulation that can help their hemispheric perfusion.
Dr. Smith, I commend you for making a cogent argument that there may be, situations for neuroendovascular intervention in these patients, and if not now, that there should be, more research done for the future to identify possibly new techniques, new technologies. I'm reminded of the situation for mechanical thrombectomy in the recent decade. In 2013, there were 3 negative trials of intra-arterial therapy for acute large vessel occlusion and stroke. But if you thought that closed the book on neuroendovascular therapy for acute stroke, you were very wrong, because just 3 years later, we had a whole slate of new trials that were all dramatically positive, showing a benefit for mechanical thrombectomy. Of course, that followed a major advance in maybe identifying the right types of patients to treat, but also very importantly, an advance in the technology with the retrievable stents. So I think would agree with the idea that we shouldn't stop research. We need to continue pushing ahead. Dr. Chimowitz made a very strong argument that he is not happy with the current state of what we have to offer for patients with symptomatic high-grade intracranial stenosis. It does appear that our current evidence base favors medical management, aggressive medical management over stenting, but it's a moving target. I do take one issue, and I'm going to let you respond to this, and I probably should have allowed Dr. Panchal to rebut your comments first, but I'll take a shot at you, and then I'll let Dr. Panchal do his part. You had a criticism of the relative inexperience of the interventionalists in Sampras. In reality, I would say that many of the centers were some of the most experienced centers in performing these procedures. It's just that there really isn't a lot of experience out there in total. And then when we actually kind of had this conversation this morning with Dr. Chimowitz's keynote talk, that when we looked into the Sampras experience and we tried to see if operator experience, the number of cases done by the individual interventionalist, whether that was predictive of the complication rate of the procedure, we did not find a correlation between experience and outcomes, which is perhaps counterintuitive. What's interesting is that we found instead that it was the high enrolling centers that did the best with aggressive medical management, which my sort of point to make with that is that in fact aggressive medical management is both a science and an art, and that there are differences in terms of experience and knowledge and expertise in medical management, neurological management of these patients. So I'm going to give you an opportunity to rebut that.
Yeah, no, I think that makes sense, and I think what can also be reflective in the difference versus the peri-procedural, complications and those reported centers who had more experience or not, and maybe looking and digging deeper in kind of the protocolized medical management after the procedure as well. I don't believe that I believe there's probably a heterogeneous sort of management with these patients. There wasn't any protocolized blood pressure. There wasn't any protocolized way of antiplatelet, antithrombotic agents in any of the stenting placement studies. So I think the argument, for, the experience of the center is not only with the interventionalist, but in the care afterwards. So I think that's probably where a lot of that difference might have been driven.
Dr. Pancho, would you have any rebuttal? I'm trying to make this a debate where we kind of...
No, actually, just to chime in on that too, if I recall, the majority of the complications occurred within the first day after stenting as well, in terms of at least the hemorrhagic complications in the primaries, or at least the higher volume centers. And so it actually leads into should and when, or if and when surgical intervention in these patients, or at least primary stenting or primary surgical intervention in these patients attains that level technologically or however else otherwise, excuse me, that is not purely a surgical approach, but rather the medical management that comes along with it in terms of integral and drips for these patients versus Plavix loads or whatever else, but sort of having a hybrid approach to aggressive medical and surgical management in these patients, preventing those initial complications that may be more detrimental to that approach, rather than the long-term complications that may not bore out should this combination kind of play out together. But I would still say that even with talking about the technologies and whatever else of surgical approach, the same applies to medical management as well, which we are sort of seeing in real time, both with the antithrombotics and anticoagulation in these patients, either at lower doses or however else, but also the addressing of lipids and blood sugars and diabetics and things like that. It still remains not optimized.
Yeah, I agree with that, Dr. Patshal, that one of the major advances in Sampras was this idea that there could be a protocol that would optimize aggressive medical management. That protocol is now more than 10 years old, and so I give credit to the investigators in the field, including Dr. Chimowitz, that are continuing to search for better ways of avoiding recurrent stroke in this patient population. Captiva, of course, is exploring new, different antithrombotic regimens, but you brought out some other, in the area of diabetes. We've been in the dark for many, many years about how best to, employ secondary stroke prevention strategies in patients with diabetes. And up until recently, we've not found that anti-diabetic agents actually reduced the risk of stroke, which is ironic because for so many of the other vascular risk factors, we readily see a benefit. When we control blood pressure, we see a reduction in the risk of recurrent stroke. When we reduce LDL cholesterol, we reduce the risk of a second stroke. But it looks like it's not all of the diabetes agents, but perhaps the ones that improve insulin sensitivity that have a specific benefit for reducing the risk of recurrent stroke. I'm going to shift back to Dr. Smith because I launched the first attack, but now I'll also give him some credit for making some excellent points, in my view, which is that some of these differences or modifications of technique may make a difference in terms of the stroke complication rate of these procedures in the brain. You mentioned one example, which was minimizing the use of wire exchanges, something as simple as that, because what we did find in Sampras, and just from our general experience, is that these wires can, sometimes accidentally perforate the artery. That can lead to a subarachnoid hemorrhage, a hemorrhagic stroke, and that counts against the stent arm. And so something as simple as that, with appropriate modifications of technique, may result in better outcomes later on. So it may not even require a huge advance in the technology. You talked about some of the differences between angioplasty alone and stenting, and then maybe the use of different types of stents, drug-eluting stents, perhaps. So I'll give you credit for making some positive points there as well.
Any other questions? Thank you.
Very good. So I think we will, at this point, yield the floor for the next debate, which will regard carotid endarterectomy versus TCAR, and Dr. Volpe will be moderating that debate.